Hi everybody, thank you for those of you who were able to wait with us. We do very much appreciate your patience and understanding this morning. We're very pleased that our presenters have been able to join us and that we are ready to bring you a really interesting presentation on understanding eating disorders in young people. We have two presenters with us today, although only one of them's name is listed here. My name's Karen Marriage and I'm a clinical psychologist who works here at the Orygen, the National Centre of Excellence in Youth Mental Health, and I'll be acting as your host. For those of you who haven't joined us for a webinar before, we would like to let you know that we do record these webinars. So if you're not able to stay for the duration, or if you have colleagues who may be interested and haven't been able to join us live today, in a short period of time, today's presentation and others that we've presented recently are available on our Orygen website. So do check back in if you'd like to refer back to the material, or if you weren't able to stay for the duration or have a colleague who might like to have a look at the content. Okay, if you've joined us for webinars before, you'll know that you have the capacity to ask some questions. So you'll have a panel like this on the right of your screen and a little section on the bottom where you can type in your questions in text. We'll endeavour for our presenters to get to your questions. So if there's something that we're not covering, or there's something that you've always wanted to know and not been sure where to ask, do type it in and we'll do our best to get to the questions. We may not be able to answer them all, but we'll endeavour to get to them. Some people find that their audio works best if they have headphones, so if you have some headphones handy, you might want to grab them now and plug them in. You may not need to do that. Okay, so that's the little text box that you can add your questions to. Throughout today's presentation, we will be giving you the opportunity to give us some answers to some questions. So we'll have a couple of quiz questions that'll give us some information about who we have sitting at their computers around the country today, what you know, and help us to think about who our audience is. So stay tuned, there'll be some polls coming up quite quickly. You'll have about 20 seconds to answer them, I think, before we move on. So let's get started. Today we're very fortunate to have both Christine Morgan and Eliza Charlotte with us to present on eating disorders. Have I said your surname incorrectly? That was correct.
You never know which one it is. I was in Charlotte.
I'm glad I got it the right way around. So I'll give you a little bit of information about our presenters today. Christine has been the CEO of the Butterfly Foundation for 7 years, and in that time has grown Butterfly into a widely respected and highly effective national organisation for consumers with eating disorders and their carers in Australia. The Butterfly Foundation is a provider of innovative evidence-based and evidence-generating services, including the intensive outpatient program and day program. Christine was instrumental in the founding of the groundbreaking National Eating Disorders Collaboration in 2009, and under her leadership, Australia has received its first federal funding for a national telephone and e-health helpline for eating disorders, ED Hope, in 2012. She's also the National Director of the NEDC and a Director of Butterfly. Prior to working within the eating disorder sector, Christine had an extensive background in strategic and business development, management of corporate services, and legal affairs in both the not-for-profit and commercial sectors. We're also very fortunate to have Eliza with us. Eliza Charlotte holds qualifications in science and health promotion and provides professional development on a wide range of health and education to a wide range of health and education professionals on behalf of the National Eating Disorders Collaboration. Prior to joining the Butterfly Foundation, Eliza has had a long career providing training and professional development, including in the areas of adolescent health and drugs and alcohol. So I think you'll agree we're in fairly good hands today, and it will be very useful for those of us who work in clinical services in particular, because eating disorders are so common that we all have young people on our caseloads who will present with issues with eating or body image, and it's nice to know that we're doing a good job by them. It's a very serious set of disorders, and I know from working clinically myself that it can be complex to treat. So we're glad you've made the time to join us today, and we hope you find the information useful. So I'll hand over.
Thank you. Well, thank you very much, Karen, for that introduction. And you've got to know a little bit us. I always hate hearing about bios when they're read. But I'm going to hand over now to Eliza to start us off. But I think she would first like to know a little bit about yourselves, which is some of the first poll questions.
Right. Thank you, Christine. And thank you, Karen, for that introduction, but also thank you to Orygen for the privilege and this opportunity to share some information with you all today about eating disorders. I'll firstly just come across to the poll questions. It's a little difficult sitting behind the screen. I always enjoy providing information, and this is the first opportunity for me to do it via a webinar, but I would welcome some information about the group of people that I'm working with today. So I'm hoping some poll questions will now come up on your screens to be able to answer, and would welcome some information just so we can get to know you a little as well as being able to best shape our presentation today. So for me, as a passionate educator, it's a privilege to talk about eating disorders because it's a really important topic. It's a really important topic because it has, in the past, had a lot of myths and misconceptions attached to it. It's also had a high level of stigma, and I think from the work that I've done in a regional context to date, there's been certainly a lot of professionals say they just weren't aware about services available, but also weren't aware about what eating disorders were necessarily, and also some of the many tools that can be used. So by the end of this, I certainly hope that we have equipped you better and added some tools to your toolkits in this area. So let's jump straight in to what are eating disorders. So just, okay. Is that going to come across?
We're just working out the technology.
PJ, do we have the poll questions answered? So people are currently seeing the question, do you currently work with people with eating disorders?
Fine.
Okay, so we'll just slow down.
No, I don't think we do. We can probably get started.
Keep going.
Yeah, we can keep going.
Great. So let's look. I will keep talking whilst you you see those questions on your screen, and then shortly information will come up to you what I'm talking about. There we go. Yeah. So what are eating disorders? And there are, as I mentioned, many myths and misconceptions around what eating disorders are, but they are diagnosable serious mental health illness. And in terms of the Diagnostic Statistical Manual, there's some core psychopathology, and those core psychopathology include the over-evaluation of shape and weight and their control for the person, to the sense that it becomes their lens, if you like, filtering in terms of their values, their sense of identity, even their sense of activities is very much controlled and based on this over-evaluation of shape and weight and control. Attached to it is an enormous psychological distress, and you'll see a quote there from a lived experience that says, having an eating disorder is like being in a personal hell, where no matter what you do or don't do, everything is wrong. It involved a lonely, isolated world of shame, guilt, and a feeling of utter failure. So we can see from that statement the enormous sense of emotions that are attached and the psychological distress where feelings of failure, shame, guilt, and everything feels out of control and wrong. Eating disorders are very much marked by disordered eating behaviours, and there's a spectrum and a scope of different disordered eating behaviours that are attached to eating disorders, and we'll certainly go into that further. But what we're going to talk about today is 4 different presentations of specific eating disorders, and now we'll go into those. So with that background of that transdiagnostic view, that core psychopathology in the back of your minds, now let's look into a bit more of a depth in terms of the 4 different eating disorders. So firstly, anorexia nervosa. And you can delve into the Diagnostic and Statistical Manual 5 if you'd like further information about this. But as an overview, anorexia nervosa is certainly the restriction of energy intake. People suffering this illness have an intense fear of weight, a disturbance in their view, and they're certainly marked by a low weight. A person, in terms of their sense of intense fear, being presented with even perhaps an apple to consume can be particularly overwhelming and induce all sorts of fears in terms of weight gain and how they perceive themselves. Now let's look across to bulimia nervosa. Bulimia nervosa is marked by binging and compensation. Now, when we talk about binging, binging is a distinct event in which a person would consume an amount of food that would otherwise consider normal. So it's not just having a video night on a Friday night with the girlfriends and you know, going through a few packets of chips and a bit of chocolate. This is a very marked, distinct, enormous amount of food for a person. With bulimia nervosa, it's marked by compensation. There's a purge, a binge, fasting kind of cycle that happens for someone with this condition. And compensation can include anything from purging to the use and abuse of laxatives, substance abuse and other things like that, and tends to happen at a frequency of 1 or more times a week for a minimum period of 3 months. Certainly the person's sense of evaluation, self-evaluation is influenced by their shape and their weight, and it's certainly a distinct difference to anorexia nervosa. Now linking into binge eating disorder, again there's some similarities in the sense of a binge, but for a person suffering from binge eating disorder, it's typically without compensation. So we don't see over-exercising, we don't see the abuse of laxatives or other forms of substances. But again, it's happening at a similar frequency of 1 or more times a week for a minimum period of about 3 months. A person with binge eating disorder experiences extreme distress and extreme lack of control around binge eating. And I know of people with a lived experience at times with binge eating disorder where not only they've consumed what would be a large amount of food, perhaps the volume of a small carry-on suitcase in one sitting, but there's their sense of being dissociated and almost blacked out during this binge. At times, I know of people that have actually consumed non-human products such as cat food or dog food in that time. So as you can imagine, enormous sense of guilt and shame and all sorts of emotions attached to that. Then the last one we'll talk about is other specified feeding and eating disorders. So they can present with any of these symptoms in any of the other of anorexia, bulimia nervosa or binge eating disorder, perhaps, but not presented with the full criteria. However, we've still got the core psychopathology going on for these people, so distinct distress, some serious medical complications, and so it just encompasses the opportunity for people in this category to obviously be treated and referred for care. I think we've got some. So we've got some key characteristics about eating disorders here. So just to summarise again, feelings of hopelessness, of anxiety, of depression, intense feelings of self-hatred, sustained by this tormenting voice of this harsh inner critic. And in a few slides' time, we'll look at what we call almost the noise going on in someone's head related to this voice and this harsh inner critic. But again, some lived experience quotes. So there is a tyrant in my head screaming abuse at me 24/7. After a binge purge episode, I feel like I have been hit by a truck. There were numerous times when ending it all crossed my mind because I was so tired. And finally, I was recently asked to sum up my experience of anorexia nervosa in one sentence. Actually, I can do it in just one word: isolation. You feel completely alone. So just to give you very much that inside view of very much the lived experience of what it's like for someone with an eating disorder. Now, it's important to put eating disorders on a continuum as a spectrum, and they certainly can be viewed on this healthy behaviours spectrum. And if we just bring up that spectrum now, overall, I think you'd all agree we're all aiming for a healthy relationship with regards to food, to exercise, in terms of socialisation, and that's where we're all aiming for that healthy views and behaviours. But as there's many influences and many factors in society that start to bombard us with all sorts of thoughts and different opportunities, and that can be from the social media bombardment to look a certain way through to many fad diets that we can be exposed to or choose to partake in. And that's when problems around disordered eating and behaviours can start to form. But then at the far end of their spectrum is eating disorders, and that sits in that clinical health problems and illness alongside things like obesity. Eating disorders are complex. We know from research that that occurs across the community. It affects every age, every gender, both male and female, different orientation, different cultural backgrounds. We do know from research also that there are some high-risk groups, and we'll talk about those particular high-risk groups shortly. We also know that eating disorders commonly occur alongside other mental health illnesses, and they have, you know, we'll talk about the commonalities there in terms of the presentation of depression or anxiety or OCD that sits along eating disorders often. We also know that they're complex because there's multi-factors that can relate to an eating disorder forming, and that includes some genetic vulnerability, some psychological makeup, and also environmental factors in there as well. And certainly medical and physical as well as psychological outcomes. Every part of a person's system with an eating disorder can be affected. I think if we just move across to another slide at the moment, oh no, sorry, in a few slides' time, you'll actually see the degree to the complexity of how many parts and systems within the body can be affected by an eating disorder. But first, let's look at the high-risk populations. Certainly, from research, we know that the peak period for eating disorders to occur is between 12 to 25 years old. But our median age for it is about 18 years. But that's not to say the patterns and thoughts have been undertaken for many years and that disordered eating patterns before that time. We also know that competitive occupations are at risk. Those people involved particularly where perhaps body shape and size is emphasised to produce a particular performance. So we know there's certainly at-risk groups amongst our athletes, amongst our dancers, amongst models, amongst gymnasts, even amongst jockeys. And I'm sure in your groups that you're working with, you'll possibly have these types of people. We also know that women sit amongst the high-risk populations, certainly from the young adolescent right through to those going through menopause and even in later years in life. Key transition periods can actually be a high-risk time as well, and that can simply be for a woman perhaps transiting from high school into either tertiary studies or further employment, or it could be a middle-aged woman going through menopause. These can be key at-risk times for someone. We also know that low self-esteem, anxiety, stress, depression and substance misuse, people in this group are at high risk. Those suffering from the illnesses like diabetes and polycystic ovary syndrome are also at risk, and certainly adolescents, for those working with young people, is one to look at with diabetic adolescents. There's a high risk of them misusing insulin, but we also know that there's a high risk attached to suffering from an eating disorder, attached to things such as perhaps food being a focus of them in order to manage their illness, and that's the same for polycystic ovary syndrome. We know, we've mentioned this already, certain psychological makeups can be at a higher risk group, and that's typically the perfectionistic or the compulsive personality. That's not to say everyone with that is going to suffer from an eating disorder, but certainly it's just good to know that that can be an at-risk group. Role modelling can put people at a risk, and certainly we can see through families with a history of eating disorders, younger people certainly be at risk if mum and dad have adopted certain behaviours or relationships around food, exercise and their perspective around their shape and their weight. And then those who are seeking weight loss, treatment or dieting. And I particularly emphasise here perhaps for reasons otherwise outside what's being medically managed. Perhaps it's for fad diets, or perhaps it's simply for emotional regulation. It can certainly put someone at risk. Let's now look at what causes eating disorders. I've already mentioned that they're complex and they're multifactorial, and there's some key ones here. So in terms of biology and genetic vulnerability, we've got some strong research to show that particularly for anorexia and bulimia nervosa sufferers, there is some genes, not a particular gene, but a group of genes that interweave with each other in terms of perhaps food choice and mood and satiety and things like that, that can put someone at a genetic vulnerability to both anorexia and bulimia nervosa. In terms of psychological factors, I've mentioned already certain personality traits, and they tend to be that perfectionistic. Alternatively, perhaps susceptible to depression, anxiety, or high stress levels. And then we have this environmental factor, and certainly some eating disorder researchers, and certainly a significant eating disorder researcher by the name of Dr. Bullock, who describes the gun analogy when it comes to eating disorders, and she describes it as the genetics loads the gun, and then the environment can pull the trigger. And if we look now at some of those environmental influences, it can be anything from having unrealistic body ideals and societal pressures. That certainly social media, we could say, could have a lot to answer for in terms of the thin bombardment that we often receive, and certainly for the males, it's often a thin muscular ideal that we're bombarded with to be the ideal. Other contexts, particularly for adolescents that you're working with, can be in that school environment, can certainly be peer pressure and bullying. There could be a significant fork in the road for someone through a trauma of some description. Certainly life transition times can be significant, illness, and as well as lack of control. And in this environmental influences, it can simply be as subtle as someone perhaps that has previously been called the chubby girl at school that now has stepped into a mission trip overseas for a period of time in Africa whilst she's away on holidays during a school summer period, and she suddenly starts to lose weight, and a significant amount of it, comes back into the school environment at the start of the year and suddenly is being accepted and affirmed for her loss of weight. It could be the environmental trigger that then starts her into a very entrenched eating disorder. Eating disorders are serious. We know that all eating disorders have significant physical and mental health consequences, and in a moment we'll present you with some slides that look at some medical complications in terms of anorexia and bulimia nervosa. We know there's some severe medical complications that affect every organ and every system in the body. Eating disorders have an increased mortality rate, and the mortality rate is the highest of all psychiatric illnesses, and over 12 times higher than other people in the general population. We know the main causes of mortality are suicide. It has an incredibly high suicide risk, with 200 times greater than the general population. Gastro complaints can feature regularly, infection due to a compromised immunity, and severe emaciation as well. So now in front of you, you'll just see a list of medical complications. As you can see, every system within the body can be affected by the complications of anorexia nervosa. And
that's interesting.
That's an interesting slide, but that does actually describe the complexities and the complications attached to bulimia nervosa. I talked earlier about the comorbidity, so the comorbidity of another mental illness running parallel to an eating disorder. And those comorbid diagnoses can typically be depression, anxiety, personality disorders, substance abuse, and OCD. Often it's the other mental health illness that can be presented. So it's really important as practitioners to be, if you've identified a particular mental health issue or concern, that perhaps it's time to be open to screening for an eating disorder that could be running parallel to another condition. We also know that the comorbid conditions frequently persist after treatment, so it's really important to address both or multiple conditions that have been presented to you. Eating disorders are common. We know from research that it affects, as it's nicely pictured there, 1 in 11 Australians in a lifetime are likely to be affected by an eating disorder, and in any given year about 1 in 20 Australians. It's a significant cause of concern, and when we look at other illnesses that you regularly might hear about, eating disorders sits alongside the likes of prevalence of asthma and type 2 diabetes. Females in a lifetime, there's some statistics, certainly 15% of females in their lifetime. Other things that may be interesting to you, particularly working with young people, is 23% of 18 to 25-year-olds experienced disordered eating in the previous 12 months associated with negative impact on their quality of life. And the number of people in Australia with an eating disorder has doubled in the last 10 years between that period of 95 to 2005. The good news is that we can carry the banner of hope for people that are at risk or suffering from an eating disorder. And eating disorders, as the statement boldly says there, eating disorders are treatable. Recovery is possible with treatment, and certainly there's some an extensive literature review that occurred there in 2002 showed that approximately 40% of people with anorexia nervosa recovered, and you can read the other statistics there. And certainly in bulimia nervosa, some really positive outcomes there, with 45% of patients showing full recovery. What is really important to understand is that early intervention within the first 2 years, research has shown to improve recovery rates and certainly reduce the risks of physical and medical complications. As it says there, 90% of patients given an effective treatment within 3 years of illness onset have a positive outcome at 5 years, something really important to remember. I think we might have a poll question coming in there. But let's keep going. One question that I'm often asked in a regional perspective is when should I be concerned, or when should I have a conversation? And hopefully as we now step into further conversation, and you'll start to see that it's important, like I mentioned, in that first 2 years of onset, it's really important to be having conversations, and if you're concerned at all, certainly stepping in. And hopefully in a moment you'll see some tools that you can use. There we go.
We do have some answers coming through to the poll question. We're just hoping we can show them to you.
Great.
There you go.
Excellent. It all looks like you're listening well. Well done. Thanks, Karen.
Actually, while we wait for the slides, we've just had an interesting question come in that's saying we occasionally run recreational cooking programs on the general adolescent ward, which ED patients are invited to participate in. Could this be detrimental to their treatment, and any guidelines we should follow? Now, I think what is particularly interesting about that, Eliza, is that we often say with eating disorders that it's not about the food, but it is about the food. And so whilst it's incredibly important to understand that the illness is one which is firmly embedded in the brain, it's a neuropsychiatric disorder, it does manifest itself very much around foods. I think at the beginning point, it is probably not ideal to make an assumption that somebody with an eating disorder is able to engage in recreational eating or recreational food preparation. That is something that for somebody going through recovery, I think you'd agree, Eliza, usually happens quite a way down the path. So there aren't specific guidelines around it, but it would be something that we would exercise caution around as any engagement with food for somebody who has an eating disorder raging in their head is very high stressful and is quite difficult for them to cope with.
Thanks, Chris. Great.
Good question to come through.
Very good. So now on to, like I was mentioning, when should we be concerned? And what we were mentioning earlier is the importance of early identification. So the key to recovery is this early detection and treatment. So as practitioners, you have the eyes to see and certainly lead the way on that front line. But we do know from research that on average it takes about 7 years for someone with bulimia nervosa, and I know from research about 10 years for someone with anorexia nervosa to actually start to seek treatment. And often they start to seek treatment for other medical complications that are actually sitting alongside, or like I mentioned before, for a comorbid diagnosis. Also, what often prevents people from seeking that treatment is this shame, this enormous shame and stigma, and even a lack of awareness that treatment options and services are available and easily accessible. We now have the beauty of so many different modes of service access, and certainly later in the slides we'll get to see that. And certainly for people with anorexia nervosa, they may be ambivalent around seeking help, not perceiving that their disorder as a problem, or seeking even to hide the symptoms. And this is related to what we call the ego chronic nature of the eating disorder for anorexia nervosa sufferers. But what you can do and play a key role in is these 3 steps. So being observers, being good listeners, and asking opportunistic questions. So now let's step across to being a good observer. So when a young person presents themselves to you, what we're looking out for is some of these things. So looking at weight gain or loss or fluctuations, significant fluctuations, seeking weight loss treatments, perhaps again not for medical reasons, gastro complaints, particularly things like reflux, infertility and menstruation concerns, other mental health issues including stress, depression, and as the others listed there. Fainting and dizziness, a very malnourished body, as you can imagine, this can be a common occurrence. And certainly as a result of a malnourished body and certain behaviours, certainly thermoregulation can be affected. So often someone will feel extremely cold, even if the weather conditions are actually not presenting as particularly cold when everyone else perhaps doesn't have the same degree of layers. And certainly looking at adolescent and child development. Are they reaching their milestones in terms of their growth? But interestingly, down the bottom there, it's really important. People with eating disorders may appear deceptively well, and certainly a level of what can be described as wearing a facade or a mask of being fine or being well when actually they're very medically compromised. Other warning signs to look out for, so psychological and physical warning signs. There's a long list there, but some key ones to look out are this sense of feeling out of control around food, very black and white thinking, perhaps having lists of good and bad, using food as an emotional regulator, and certainly I don't know if anyone ever gets a little bit hangry pre-lunch or pre-dinner. I know I certainly do at times, but certainly, as you can imagine, there can be shifts in mood attached to certain eating behaviours or disordered eating patterns as well. So physical signs, that again we've talked about some of those already, but one I'd just like to point out there and link to one of the NEDC resources is calluses on the back of the knuckles and damages to the teeth. If anyone is working in the dentistry field or has any colleagues in that area, the NEDC has a number of resources available, one certainly for allied health professionals and GPs, but we recently have done others for midwives and those working with pregnant women, but also dentists as well, because they can certainly be a key player in that first early identification and detection. Behavioural warning signs to look out for, so evidence of dieting and binge eating, the frequent trips to the bathroom shortly after meals or even avoiding social situations, changes in clothing style, certainly obsessive rituals around food preparation. So I certainly know that some people with a lived experience, they will talk of a contamination level with their food if it hasn't been prepared in a certain way, or if it's not presented on a plate in a certain pattern or order. And certainly around eating disorders is a very marked secretive behaviours. In a school context, it could be something like hiding food wrappers in lockers, through to hiding foods in bags and things like that. So what can you do? There's some key things that you can start to screen for with regards to eating disorders and ask some opportunistic questions. These questions have shown to be very positive in their use. So asking questions if you suspect an eating disorder, like many people have concerns about food and weight. Do you have any concerns or worries about these things? Similarly, many people have trouble with eating too much. Has this ever been a problem to you? It's very much about open questions. It's very much about normalising this as a concern, and certainly helping to reduce the stigma attached to it, and certainly helping to open that person's perspective up to some treatment. Certainly, a high sensitivity has also been shown for bulimia nervosa sufferers to questions such as, are you satisfied with your eating patterns, or do you eat in secret? If there's a response of yes to any of these questions, obviously further questions are justified and worthy. One screening tool which is shown to be very useful, and this is described in the NEDC resource for GPs. You're welcome to download any of our resources as PDFs online. But this screening tool is the SCOFF tool. It's an unfortunate acronym, however, it might be memorable in that sense. But it came out of the research in the UK, hence as we go down the list we see one stone. But let me just describe to you why this is a useful tool. You can massage these questions. It doesn't have to be specific. You can rearrange it as you desire, but useful tools to start to get from the person some key indicators of an eating disorder. So are you making yourself sick? Do you feel like you've lost control? Have you lost more than 6 kilos? Do you believe yourself to be fat when others would say you are too thin? And then a really important question, at times, if you can't ask anything else, perhaps this is one to throw into the mix, is would you say food dominates your life? Would you say that
Absolutely.
sufferers cannot deny that in their head, even if they cannot verbalise that to someone?
That's right. And I think what you're saying is so important, that somebody with an eating disorder finds it extraordinarily difficult to self-disclose. They need an opener. So asking the questions is incredibly important.
Great, thank you. Now let's look at other tools. So that's just one example, the SCOFF tool, but a good one. And if you'd like to go into further depth, you're welcome to Google and look in further into these diagnostic assessments, but they've certainly been well used, and certainly guidelines around the use of motivational interviewing is really useful. I mentioned earlier that the risk of suicide amongst our group of sufferers with an eating disorder, and it's so important. That's one of the many things to do a risk assessment through. But it's really important to do a thorough multidisciplinary assessment, and that's covering, because I mentioned, all elements of a person's body, from their psychology to their nutrition to medical complications that can arise. It's really important that on board, ultimately, we have a group of professionals looking after someone with an eating disorder, like a GP or a medical practitioner, a dietitian that can look into the nutritional aspects for a person's treatment, and then certainly a counsellor, a psychologist, a psychiatrist in terms of doing that psychotherapy. Ideally, people are talking in terms of their care team and sharing the results in a combination of contexts. And then that table nicely highlights different things under the different categories that we should be looking for, and also some tools and valuable guidelines that you can access in terms of helping you as a professional to do that risk assessment. But eating disorders are known to be challenging as professionals. In a professional capacity, it's often challenging to work with someone who's at risk or suffering from an eating disorder. And that's because when people present initially, you often come up against some of these common features, like a level of ambivalence regarding change, a denial that there's even an issue or a presence of an eating disorder. All sorts of emotions may be felt by this person in terms of protecting the very thing at the moment that is actually helping them to cope and to manage through life. So they will be defensive, they will potentially be evasive and resistant, and perhaps even hostile. They'll be minimising the severity of the disorder, and there's certainly at times a social norm that goes on, particularly amongst young people and teenagers, where they'll be like, oh, all my friends are doing this. So be aware to that as well. Certainly there's a hostility towards clinicians, and this can be for all sorts of reasons. Perhaps it's a previous experience where it wasn't a particularly positive outcome for the person working with that professional, but otherwise some of the steps that are often taken can be particularly challenging for that young person or that person suffering, so there can be a level of hostility that is induced there. Certainly, you may be seeing someone engaging in a level of deception and secretive behaviours, and it's really important to separate behaviour from who that person actually is and the value of that person. And then finally, the symptoms serving as a function, meeting a need for that person. And certainly, I mentioned earlier, the egocentric nature of anorexia nervosa serves as a very valid function to that person, to the sense that research has shown they might describe it as being an intimate part of their being. At this stage, I'm going to hand over to Christine.
Thank you, Eliza. Look, that was an absolutely fantastic overview of the pathology, etc., that goes with an eating disorder. Look, at this point in the presentation, what we thought might be useful is if we can kind of take a little bit of a sideways step and perhaps just give you some insights, and Eliza has touched on this, as to what's actually going on for the person. How are they feeling? Because I think the complexity about treating an eating disorder is you can look at the symptoms, you can even understand the causal factors, but it's very individualistic to the person. So the solution to recovery is very much about engaging with the person. So just to start us off on this particular part of it, I think there's no better voice than the voice of somebody who's actually gone through it. So we've just collated a few accounts. Let me go through them for you. You can read them, but maybe if I say them, they'll come through. The thinner I get, the better I feel. I'm actually proud of my very stoic, Spartan existence. Now, just to key that into a social impact, how many times do we, just in general social conversation, quite admire somebody who's on a diet and actually think somebody else is really quite slack if they've put on weight? So that person has got something happening in their head, but it's also being impacted by our societal part. They like to feel stoic and Spartan. This has become the most important thing I've ever done. Even though I like to think of myself as cured from anorexia now, I do still miss it sometimes. I would compare putting anorexia behind me to losing my best friend. My illness is my friend. It's the only thing I'm good at. You're beginning to see that the brain is really playing in with the messaging here for somebody with an eating disorder. Then we start to look at some of the shame that goes with it. It's embarrassing. I just wish I didn't do these things, but I can't help it. The moment I feel stress, I just start eating and I won't stop until it goes away. It's such a release. I know all day that I'm going to binge. I just delay all my feelings to that moment, and once the decision's made, it's out of my control. Then I have to purge. It's the control after the release, like it was when I used to cut myself. And for those of you who are working in this field with young people where we have such a high incidence of self-harm, we are seeing quite a strong correlation between people with an eating disorder and self-harm. There is that common component of I need to release myself from something. Now, what I think might be useful as we start to look at how do we engage this person in treatment is actually to look at the impact of what starvation is doing. As Eliza spoke to us about, the causal pathway into an eating disorder is certainly a genetic vulnerability. With that makes up approximately 50% of somebody's vulnerability. We know there are emotional stresses. What is really interesting is that it appears that the trigger for many things, and Cindy Bulick, as you've said, would aim for this, is actually loss of weight or nutritional deprivation. And when you speak to the neuroscientists who look into this, what starts to happen once an eating disorder has taken effect or taken hold is there are changes in neural pathways. Now, if you go back to the Minnesota study, and a lot of you are going to be very familiar with this, but some of you may not, it's fascinating. This was the research that was done pre-ethics days when you could get away with doing these things, where effectively conscientious objectors to the war were asked whether they would participate in a study of what was the impact of starvation. And this was being done in the United States because they anticipated at the end of the war that they would have to be dealing with a whole number of people released from concentration camps, etc., where they really had suffered very severe starvation. What should they do about it? So without going into all of that, we could talk about that for ages, but the interesting things to pick up for us when we look at an eating disorder person and what has happened to them, particularly if they've become involved in starvation. Now, for somebody with anorexia nervosa, that will be a very, very low body weight, but you can also starve if you are binging on food which is not giving you nutritional deprivation. So firstly, there is significant impairment to the problem-solving and decision-making component, the cognitive part of the brain. It's affecting your concentration and your alertness, but it does actually affect your comprehension and judgment. That's incredibly important. If you're about to try and engage in psychotherapy with a patient and they actually have a brain which is working against it because it's being cognitively impaired, that is imperative for you as a therapist to be across. Behavioural. This is fascinating, and I don't know if any of you have ever done this experiment, but if you want to try it, I've done it to myself. If you deprive yourself of food, somehow it's almost like you go the other way and you become very preoccupied with it. I tried it with myself once when I actually don't like ice cream. I don't like it at all. And I said to myself, I'm not allowed to have ice cream. And the more I said to myself, I'm not allowed to have it, which is happening in somebody with an eating disorder, I will not allow myself to eat food, I started to just think of nothing but ice cream. Very simplistic, but for the person who is actually going through the impact of depriving themselves of food, they become incredibly preoccupied with it. That sets up incredible complex tension within the person, and they start to get into quite disordered behaviours, and these are symptomatic across people with eating disorders. Again, the neural pathway changes are driving these behaviours. They start to hoard food. They eat it ritualistically. That tries to take some of the fear away from it. One of the most important things to remember for somebody with an eating disorder, particularly for somebody with anorexia nervosa where they've continually deprived themselves of food, is that they actually lose control of appetite. And you will often find for somebody with anorexia nervosa, they don't have an appetite. And if you think about it, because they are going down to such a low body weight, they actually have to be overriding what for those of us who don't have an eating disorder is just a desire to eat. But also for somebody who binges, that sense of loss of control. I'm no longer eating because I've got a natural appetite. The psychological problems and the psychosocial. And what was fascinating in the Minnesota study was that these were people who had pre-starvation, had no such overwhelming preoccupation with food. So it is something that does happen biologically and neurologically for people. They do get depressed, they do start to have mood swings, and they do become more withdrawn and isolated. Eliza mentioned before the noise that is going on in somebody's head. And if you can imagine, it's kind of like sometimes people with eating disorders will say, I can't turn off my head. It doesn't mean that they're hallucinating. They're not having those kind of experiences where they genuinely are hearing a different voice of a different person. But it is chatter, it's noise, it's conflicting thoughts. And they can't escape from it. They kind of just want to run away from it. They can't. As we've just talked about, there's the impact of starvation and what that's doing to them. There's an incredible feelings of stress. That inner critic is going on. You shouldn't have eaten, you've eaten too much, you haven't eaten enough, you've eaten more than somebody else. There's the habitual behaviours and patterns that are happening. As Eliza has said, often that's happening through the framework of a perfectionistic personality. So they're feeling, I've failed or I'm about to fail. Social pressures around what you look like. All of the hard work for somebody going through an eating disorder. If you're trying to starve yourself, that is actually really hard work. If you're trying to not binge, but then you binge and then you purge, that's hard work coping with it. All of your life experiences that you're trying to go with, your own values you're putting on yourself. And the effect of that, as you can see on the right-hand side of the slide, is for the person that you're trying to work with who has an eating disorder, they genuinely have a loss of alternatives. They aren't in a position where those of us who aren't coping with an eating disorder can look at a number of different options. They can't. They can't see their goals, they can't see different identities or even different coping strategies. So, if you're looking to work with somebody who has an eating disorder, I'm just very conscious of the time here, so I'll try and walk through these. But one of the most important things you can do if you're trying to work with somebody with an eating disorder and help them to actually achieve recovery is, as I said at the beginning, you've got to work through the framework of who they are themselves. And in a therapeutic sense, we talk about this as building collaboration with the person. What you're really, I sometimes put it this way, you're looking to get to know that person, and you're looking to try and find within that person their own unique strengths, their own unique engagement with trying to be healthy, and you're trying to bring that to the forefront. So focusing on things such as recognising their strengths, recognising anything within them which might start to look like a little bit of positive help seeking, some resilience. Draw out those attributes. Start to try and bring to the forefront those things which will be positive and helpful for them. Absolutely, utterly, whatever else you do, create a safe space and don't be judgmental. As therapists, you will hear some things which, particularly if you're just starting to work with people with eating disorders and they start to disclose, they are quite shocking. And that's why the person feels so ashamed. So the most important thing is to be non-judgmental and create that very safe space. The safer somebody feels to disclose, the more they will actually tell you and you can actually try and help. Never, ever, ever, please try to motivate through fear or stigma. You are dealing with people who are hating themselves. They feel around them the barriers of stigma. They're incredibly frightened. So please never go down that route. You will feel like it sometimes, because one of the interesting things about an eating disorder, as Eliza has said, is the resistance somebody will have to treatment. And sometimes you just want to try and break through. You want to try and frighten them for their own good. It just doesn't work. Another thing to not do is to not focus in on the behaviours or the measurements. Yes, they're doing very disordered behaviours, but that is symptomatic of the illness. The illness is happening in their head, not in the behaviours. It's a bit like dealing with taking the Band-Aid on and off rather than the injury that's actually happened. Certainly don't glamorise or normalise in any way the eating disorder behaviours, and always, always, always give them hope that recovery is possible. I think here we can just once again, I think I've probably said most of those things, which is about building collaboration. Collaboration I like to define as, we're not even just a team here. I'm using my strengths to help identify your strengths, and your strengths are enriching me. So it's very much a collaborative therapeutic relationship. It is sometimes...
Sorry, can I interrupt for a moment? Chris, we've had a question that said, could you please comment on the effectiveness of family intervention treatments such as the Maudsley model?
Certainly.
Just acknowledging the time, shall we just skip forward through?
I think we should. We should.
Important information to do is motivational and stages of change. But that's something, there's certainly some good information available to you out there. But we'll just go ahead a few slides now and look at some of the evidence-based treatments and key elements of care.
Okay, and I think we can even skip. So look, what we will do is we'll walk through all these. We will actually get to the evidence-based treatments, as Eliza was just saying. And certainly, as the questions just come through, the family intervention treatments such as the Maudsley model is what we regard as the plated standard. So it is certainly the one where how this effectively works for those who are not familiar with treatment is to say, for a young person with an eating disorder, we very much need to look at the environment which they're in, which is their family. And the Maudsley-based FBT is about how you can actually harness and affect the hierarchy and the parental norms of a family to actually, if you like, help the young person not behave in accordance with where they want to go to with their eating disorder. So you're very much using the family environment with the support of a highly disciplined and qualified team to actually help engage that young person in eating behaviours that override the eating disorder and in psychotherapy and behavioural changes that will help them address it. So whilst it is certainly the gold-plated behaviour, it is, the gold-plated treatment, it is by no means the only one. And what we will say is that for those families where Maudsley is not working, there are other options for you to go through. You'll see from the slide that's up there at the moment that there's a whole range of treatments. We could spend an hour just going through each of those. So, Eliza, unless you wanted to say anything further on those?
Other than specifically to address the effectiveness question that we had come in, and a great question is, I believe from research, it's around a 70% success rate for working with young people is the FBT.
Look, I think that is right. It is certainly the case. That said, there is there are some criteria to assess as to whether it's the appropriate treatment. So certainly if it's assessed to be the appropriate treatment for your young person, that is a very effective way to go through. Having worked extensively with some families where it hasn't worked, it is important to remember if it doesn't work for you, then there are other options. But yes, I would certainly agree, Eliza, that if you have a young person and they've been assessed as being appropriate for Maudsley-based FBT, go for it. It is a very good model to use. They're the primary care interventions, which we can just look at. I think we've talked a lot about that. I would like to just say, now that we've actually been able to take this question about the family, and another question's come through which really is starting to look at this. What can you do if the family is not on board with helping the young person? I'm going to take the question and wind it back into this slide. It is extraordinarily difficult if the family is not on board. So let's just acknowledge that up front. To recover from an eating disorder does require the person to have around them a cohort of support. And in that space, we all recognise that families are the optimum. So firstly, if I look at the positive side with families, families have an incredibly important role to play in helping their young person just be held and go through their treatment and help actually do the normalisation of eating. If a young person does not have a family that supports them, it is incredibly important to try and build around them that cohort of support. Because whilst you can be with them in that moment of treatment, 95% of recovery of an eating disorder happens in the person's own time. And for that, they need supportive people around them. So certainly, from the perspective of families, it's important to say families are never to blame. It is not about sort of anything being particularly destructive in the family, etc. It is very difficult to live with an eating disorder. But picking up on the question, if you have a family which is not on board, then it is important to surround the young person with supports.
And can I just add to that, Chris, is also, I think, some psychoeducation for family as well.
Yes.
So certainly there's so the NEDC has a carers booklet,
yes,
which has some valuable information for carers and families in terms of helping to equip that family alongside that young person.
I think you raised a very good point there, Eliza, because I think often families not being on board is because they're still coming from a space where they believe this is about a young person just choosing not to eat properly. So I know, in fact, anecdotally, talking in particular to dads, often dads just don't get it. Though interestingly, as we're seeing eating disorders becoming more common in males, I think we're starting to break down those barriers. But you're absolutely right. The whole role of the family and being a carer is one where you do need some help and education yourself. So as we've got just another couple of minutes to go, and then we'll keep an eye out for any other questions that you may have. There's some great resources for families if you're not in the Maudsley model, or for any family. So again, coming back to a family who's not on board with helping the young person, as Eliza suggested, give them some resources. The work done by Janet Treasure over at the Maudsley Centre in London is unparalleled. She's absolutely fantastic. She's a neuropsychiatrist who is particularly done a lot of work with how families of all different types can be engaged in helping their loved one with an eating disorder. And guided self-help is good, particularly for people who are suffering from bulimia and binge eating disorder. Recovery, as Eliza has said, is absolutely possible. There are different criteria for recovery, certainly the diagnostic, but you also look at the behavioural aspects, physical health, psychological aspects, and engagement in life. And just as we get, this actually is a really important one to spend just 1 minute on. What are the building blocks for recovery? These are the attributes that have actually been informed for us by people with a lived experience who have come back and said, these are the things that have really helped me as I've worked towards recovery. Having a sense of hope that I actually can recover. Understanding I have a choice. And as you start to work with people and loosen up their thinking, they can start to actually make decisions about what it means for them to have a more meaningful life. Connection and participation with others, relationships are incredibly important. Being able to recognise coping strategies for when they are particularly vulnerable. Enabling their wider communities, such as families, such as workplaces, to understand what they're going through, and always to provide them with opportunities for ongoing professional support. Relapse is unfortunately still too high. Some more personal experiences, I think we can probably work through those quickly. You can read those. Again, supporting the person is incredibly important if you should treat them. And then where to go to for help. There is the Butterfly Foundation helpline, which runs from 8 a.m. to 9 p.m. every day. It's staffed by professional counsellors, telephone, email or online chats, and the details are there. And also here we have, you might want to walk through some of these other ones.
Sure. There is a wealth of information available to you. Certainly I encourage you, if you haven't already perused the NEDC website, please do so. But there's certainly many other services and opportunities for you to do some further gathering of information, certainly through some fact sheets. And it's not listed there, but even the mental first aid guidelines is an excellent resource to you as well. But certainly here in Victoria, there's the likes of Centre of Excellence for Eating Disorders. In New South Wales, the Centre of Eating and Dieting Disorders provides an online module for training, and certainly other academic sources for you with ANZ and the Journal of Eating Disorders. Next. And so in terms of NEDC resources, there's the website links there for you. In terms of youth focus, there's an excellent resource which has become a web-friendly app. As you can see there on the screen, if you bring it up on a mobile phone or a smartphone, it looks like that. You can drill it into it using the light bulb because I want help. The light bulb because I need more info, or the buoy which says I need help. And certainly there's some really good information there that's got a youth focus for it. And it certainly was produced with the assistance of young people to make it have the right feel and fit. And as I mentioned earlier, there's a variety of resources the NEDC has, and it's listed there in terms of different relevant professional resources which may be of interest to you. So I encourage you to look online. And then just opportunities to keep in touch. Email us, hook into the various opportunities, whether it's via Facebook, whether it's via Twitter, visit at the websites. Please keep in touch, and very much available and open to support you in your service areas.
And I think that's it.
I think that's it.
Thank you. Okay. Well, I hope you agree that that was an incredibly informative presentation, and you have a lot of information to follow up if you have more information required. So if you're interested, or if you are wanting to do some more treatment, or if you're needing more information, I think you'll agree that you now have a wealth of information to dig into that might be of assistance to you. So I'd like to thank our presenters today and hope that you found it useful. A reminder that the presentation has been videoed and recorded and will be available on the Orygen website shortly, and you'll receive a certificate of participation via email if you've registered and participated today. Okay, so we've had questions as we've gone along, and they've been very useful. Thank you for sending those through. I thought I would just take the opportunity to let you know that Orygen are offering a certificate in young people's mental health and technology that you may be interested in. There are online learning modules on our website that you can access that will assist you to think about how you might use technology in your treatment of young people, because it's where they are, it's what they're using, and many of us clinicians have a little way behind our younger clients, so if you're interested you might like to check that out. And if you've enjoyed this webinar, you might like to have a look at the next lot we have in our series. On Tuesday morning we're having a look at self-harm, particularly for those people who work in a school setting, and on the 4th of May we have a webinar designed for people who work in sporting sectors. So we know many of our young people are engaged in sports, and often people at the front line in their lives are the communities around their sporting organisations, and they want to do a good job and often aren't quite sure where to begin with mental health. So if you have access to local sporting communities where you think they might benefit from a little bit of information about what's going on with the mental health of the young people that they're seeing in their sports, they might be interested in that free webinar that's coming up on the 4th of May. So we'd like to thank you for your participation. We're sorry we were a little late getting started today, but I hope we were able to get most of what you needed into the shorter space of time. We hope to see you again shortly.